thank you all for staying and have the stamina to stay for the fifth and last presentation of the session. We will start with our first speaker. Our first presenter is Dr. Jose Diaz, whom you have heard this morning. Jose. Dr. Diaz is internationally recognized for his contributions and surgical practical model developments in vascular disease research. He is a professor of surgery and director of research lab in Vanderbilt University. He's interested in surgical diseases, vascular biology, immunology, and he has published greatly and extensively on these topics. Jose, the floor is yours.
Thank you very much for the kind introduction. The title of my talk is Models in Venous Thrombosis Translational Research. I will introduce the translational research to make sure that we landed in the two main topics for this talk. I don't have any conflict for this presentation. So when we talk about translational research, the steps from preclinical models to put a concept into the clinical practice is very complex. This is an example of what happened when we develop a concept and we put it back to the patient in industry for drug developments. However, in terms of what the investigators are interested in is that to move a concept for this preclinical research, or A, and translate this into the patient, which is a point B. Thus, translational research generally involves taking these scientific discoveries from the laboratory and translate into the practical applications that can benefit human health. That is the definition for translational research. And the NIH outlines the critical stage of translational research in this classification between translational 0 or T0, basic science, all the way to T4, public health. But again, we are talking about translating the concept between A and B. And in order to do that, we should understand, I should say must, understand the available models, but also we should understand the disease that we try to model. And this is what we will develop in the rest of the slides. So let's talk about the disease. Physics and biology of the complex scenario called deep vein thrombosis. So these two figures try to summarize some of the things that we learn from flow in the deep vein system. But I would like to direct your attention to figure B, in where a jet between the two valves has been determined, and the flow goes into each of the valves. You make a little vortex and go out. However, lately, another vortex was identified. It's called the inverted vortex because it's running the opposite direction to the main vortex. The important thing about that inverting vortex is that also it's a trapped vortex. It spends more time than we would like to be in that particular area. Now, if we translate this into what's happening at this particular or local level, we have cells that are part, endothelial cells that are part of that valves. And if we think that the oxygen that is the nutrient, the main nutrient for these metabolic activities in those cells are coming from the bloodstream, and we need to think that this blood or these red blood cells are already in the vein system, which is a post-capillary situation, we need to understand easily that the oxygen level on those red blood cells are already low. And if we trapped in an inverted vortex, the nutrition for those particular areas is very low. So if we think in physiology, when we learn this in the med school, we need to refer to the hemoglobin curve or the dissociation of the hemoglobin in the red blood cell. And in that particular area, we think that this curve is shifted to the right, which is happening in other type of disease status like sepsis. But in this case, it's in a local level. Now, if we understand that this is what we suppose happened in the valve area, this particular local area is under hypoxia. Now, what happened or how the endothelial cell responds to that hypoxia is by endothelial activation. What that means is that it secretes or responds to that producing many of the inflammatory markers that we know, but more important, P-selectin, which it will bring the neutrophils to the area, and that will lead to different events, production of microparticles, but also nets. Those interact with the coagulation factors. Now, if you think that all the coagulation factors are already there and are trapped in this inverted vortex, well, this is a very interesting set to form a clot. The cascade coagulation take place, and the fibrin start making the mesh together with a chronic inflammation. This is kind of a cartoon how the deep vein thrombosis can initiate. Now, not everybody develop a deep vein thrombosis. We have natural anticoagulants, APC, and different systems that are protecting us to develop a deep vein thrombosis, but also a fibrinolytic system. But in those patients that really develop the deep vein thrombosis, this is the very beginning. Deep vein thrombosis is a process with a unique degree of complexity, from this thrombosis in the valve all the way to occlude a large vein in the deep system in acute phase and a chronic phase. Now, if we think in the natural progression of the deep vein thrombosis, this cartoon will represent all the time progressive from the top to the bottom. The first steps are related to the thrombus initiation and progression. There is one direction of the thrombus at that point that grows toward to the heart, and at that phase, the patient is asymptomatic, even though with models today, we understand that there is inflammation in that wall. Now, when the time progresses and the thrombus formation progresses, arrive to the point in where the vein is completely occluded. That is when the thrombus changes completely the dynamics, and then that thrombus grows toward to the heart, but also backwards and also in all directions, making the patient realize that something is going on, pain starts, and of course, because it's a complete occlusion, edema forms. The natural evolution also has 3 different potential outcomes. It never reopened. There is an incomplete reopening with reflux and synechia, and total reopening with minimal wall impact. Now that we talk about the point B in this scenario, let's talk about A, the modeling of the diseases. In brief, we can classify these animal models in conceptuals or biological system. Conceptual models are mathematical models, computational models, and now we start talking about artificial intelligence. But also the biological models are the benchtop work, organ on chip, or the animal models itself. Now, animal models are very interesting because they provide a nice platform in where we can understand mechanism of biology, but also ensure that therapy are safe and effective for human use. When we talk about animal models, also we need to deeply understand what they provide, what they can provide, but also the applicability of these models. These have advantages, disadvantages, and application, and limitation also. And we need to understand each of these points for each of the models that we have available when we have more than one animal models to study one disease. Most of the models do not replicate a disease 100%. Now, in this case, the investigator needs to understand clinical scenario of the model that should represent, including relevant time points that they try to answer questions, and what outcomes we will be measured, and the available resources that are, all of these combined are important for research. Talking about the thrombosis model, first of all, modeling should be incorporated to the multidisciplinary vascular research team. It's interesting to think that other components of this team are very well known, but modeling usually is not included. There are basically 2 types of animal models that we talk in deep vein thrombosis, the small animal and the large animal models. We identify 7 different small animal models to study DVT in different stages, but we can summarize them in 3 different types of animal models: the ligation model, the stenosis model, and what we call the EAM or electrolytic inferior vena cava model that we developed years ago. To talk about the ligation of the stenosis models, for us that we are surgeons, we understand easily surgical techniques. So I will spend a little bit of time in this slide. In mice and rats, what we do is separate the aorta from the inferior vena cava below the level of the renal veins. And then a prolin 70 is passing below the inferior vena cava at that level. For the ligation model, which is the slides that you can see on the left, we have a complete ligature, and that established the model itself. Now, for the stenosis model, we also have a complete ligature. However, we interpose a 30-gauge needle in where, after we completely ligate the prolin, we remove the needle, and then the stenosis is created. Now, for the EAM, or the electrolytic model, what we use is a copper wire that is inserted in the vena cava, and that generates, we can go in detail later, but we generate a prothrombotic area that leads to inflammation and promote the different stages of the thrombosis in this animal model. Now, the big difference between this model and the other two is that this thrombus grows up to 80% of the lumen of the inferior vena cava, which allows a constant flow, and we will see later why this is important. We recently, in 2019, we were able to publish, in 2019, we were able to publish consensus that is very interesting work. It took us up to 5 years to put together this, but the 7 models that we identified as small animal models, we follow potential research questions and offer this algorithm in where you can have a first model of choice or a second model to choose. I think it's important that in any animal models, we standardize these models and we provide algorithms so investigators can navigate these questions and choose the better model for their research question. Now, talking about large animal models is a different component. It requires 2 types of teams, anesthesia and surgical, like in patients. A surgical team. And usually what it takes is endovascular techniques in where we use balloons. Those balloons can be sitting in the iliac vein, for example, as this cartoon represents, and 2 balloons isolate the segment that after hours the thrombus is developed. Now, there are other models in where we use 3 types of balloons, 1 sitting in the inferior vena cava and 2 in the iliac veins to provide even larger type of clots. Now, these are more expensive, but also when we try to test device, the devices need a large cardiovascular system to be tested. So this is probably one of the best models in that regards. But also, the large animal models provide a translational phase for the preclinical research, which sometimes for FDA requirements are very important also as a second model. Interesting about the large animal models is that we can perform studies that are similar to humans. So usually it's easy to correlate between large animals and the human pathology. So in this slide, that is the last one for this presentation, I bring to you an example of model applicability, because I talked to you about deep vein thrombosis, and I talked to you about animal model, but when we need to decide which model will be better for different stages of the disease that we try to study, it will be something like that. On the left, you have listed different stages of the deep vein thrombosis. And on the right, you have small and large animal, the EAM, the stenosis, and the ligation. And the X that I just displayed there are probably the model that apply better for these different scenarios. You can see, for example, that the stenosis model, the ligation model, and the large animals all coincide in this particular part in where the thrombus is acutely occluded and also the chronic phase. However, we were missing for a while this initial thrombus initiation phase, or even when they're reopened with synechia. This is what we developed the flow model that I presented before. So with this, I would like to summarize that translational research generally involves taking a scientific discovery from the laboratory and translate it to practical applications. Hypoxia could be one of the main factors that initiate deep vein thrombosis in the vein valves. Most of the animal models do not replicate the disease 100%. All models had advantages, disadvantages, and applications, and choosing a model that will answer your research question is the way to go. Sometimes it's necessary to choose more than one model to understand one disease. Thank you very much for your attention.
Thank you, Dr. Diaz. Our next presenter is Dr. Anthony Camarata. Dr. Camarata is a world-renowned vascular surgeon. He is now a director of medical of Innova Heart. I have known Dr. Camarata for over 45 years, and it is just wonderful to have him here. And he is really a friend of CVR. He has special interest in venous thromboembolic diseases, complex deep venous reconstructions. He has published extensively on these subjects, and he is a past president of American Venous Forum. Tony, yours.
Well, thank you so much for that kind introduction, Dr. Kelsey, Dr. Soufiane. Peter, thank you for the invitation to join this remarkably good program. So I'm going to talk about the management of iliofemoral DVT. It's been a special interest of mine for quite a few years, and what we've learned from randomized trials, because there are data hidden in the trials that I think once we know about the data will help us in the management of our patients in the future. These are my disclosures. Both of these are NIH-sponsored trials. It's been a number of years that we have appreciated the post-thrombotic morbidity of iliofemoral deep venous thrombosis treated with anticoagulation alone, and Susan Kahn and her colleagues reminded us of that, showing a significant increase in the frequency and severity of post-thrombotic syndrome treated with anticoagulation. But just so we all know what we're talking about, especially extensive iliofemoral DVT, is this young woman who had a large operation on her spine and then developed a phlegmatic limb about 5-6 days post-op. And we could not treat her, of course, with thrombolytic therapy, so I operated on her. And we did a venous thrombectomy. You could see the transverse venotomy above the saphenofemoral junction, the common femoral vein there. And you can see the enormous amount of thrombus that occludes the iliofemoral system in many of these patients, especially those with extreme swelling and pain. If we restore patency and eliminate the thrombus, we can anticipate that they will do well, as she did, as you can see the 3-year post-op photograph. So there's 5 randomized trials of patients with iliofemoral DVT. The Scandinavian trial randomized patients to venous thrombectomy. It's a surgical trial, venous thrombectomy versus anticoagulation. El-Shawari, catheter-directed thrombolysis, but the endpoint for El-Shawari's trial, the endpoints were patency and valve function. And then we have 3 trials, the KVEN trial, the KVA trial, and the ATTRACT trial, randomizing patients to catheter-directed thrombolysis versus anticoagulation for iliofemoral DVT. And you can see Gunnar Plata's summary of the data on the venous thrombectomy patients that did much better if they were randomized to venous thrombectomy versus anticoagulation in terms of patency, lower extremity venous pressures, swelling, and post-thrombotic symptoms. El-Shawari demonstrated that in those patients randomized to lysis, there was significantly better patency and significantly better valve function in those patients who had been treated with lytic therapy. So now we have these 3 trials that I'm going to focus on that treated patients with catheter-directed versus thrombolysis, but the technique is so important, and that's what I hope you take away from my presentation. The KVEN trial by Tuna Enden and her colleagues from Norway investigated whether the addition of catheter-directed thrombolysis to anticoagulation reduced post-thrombotic morbidity, and the endpoint was a Villalta score of greater than 4 at 24 months. And each of these 3 trials has the same endpoint, the Villalta score, one at 12 months, which is the CAVA trial, and the other 2 at 24 months, as you will see. However, the technique that they used was to put a catheter in and then start a low-volume infusion, meaning 17 to 25 cc's per hour. No pulse spray, no mechanical manipulation of the thrombus, just a low-volume infusion. So there was no clot manipulation, and they had no initial high-pressure pulse spray. It was a positive trial. They showed that there was less post-thrombotic morbidity defined by a Villalta score of less than 5 in their patients, and there was a correlation of patency with a low Villalta score. However, what the CAVAN trial did not show was that there was no reduction in moderate or severe post-thrombotic syndrome, there was no reduction in pain and swelling, and there was no improvement in the quality of life in those patients who were treated with catheter-directed thrombolysis. So they reached the primary endpoint, but all the clinically relevant endpoints were no different. The CAVA trial studied patients with iliofemoral DVT, randomizing them to ultrasound-accelerated thrombolysis with the ECHOS catheter and high-dose urokinase versus standard anticoagulation. They, too, used catheter-directed thrombolysis via drip infusion, a low-volume infusion, which you're limited to the volume of infusion with the ECHOS catheter to 30 to 35 cc's per hour. There was no mechanical clot manipulation and no upfront pulse spray infusion. And they did not show any difference between the control group and the catheter-directed thrombolysis group. Likewise, when we looked at the other clinically relevant outcomes, there was no reduction of any PTS, so they did not reach the primary endpoint. There was no reduction in moderate or severe post-thrombotic syndrome, no reduction in pain, no reduction in swelling, and no improvement in the quality of life. Completely negative trial. And then we have the ATTRACT trial, which is an NIH-sponsored trial, and we had 391 patients with iliofemoral DVT, randomizing them, importantly, pharmacomechanical thrombolysis versus anticoagulation, and the mechanical I want emphasized. The primary endpoints, the same as the other 2 trials, any post-thrombotic syndrome defined by a Villalta score of greater than 4, so 5 or more. There are important secondary endpoints, just like the other trials: moderate and severe post-thrombotic syndrome, pain, swelling, and quality of life. The technique included mechanical manipulation of the clot in these patients. That included the use of angiojet, the use of trellis, and then an upfront high-pressure pulse spray infusion into the thrombus, followed by catheter-directed thrombolysis with a large volume infusion, meaning 100 cc's per hour. And in the first hour in this patient group was about 120, 130 cc's with the pulse spray infusion. As you can see, the Villalta score of greater than 4, there was no difference between the PCDT group and the control group. But we argued, when we were writing the protocol for the ATTRACT trial, we argued about whether we should use the venous clinical severity score or just the Villalta score. Well, we finally decided on the Villalta score. If we would have chosen the venous clinical severity score, it would be a positive study, and we'd be very happy, and we reached our positive endpoint of significant reduction in post-thrombotic morbidity. But we didn't choose the VCSS as a primary endpoint. We chose it as a secondary endpoint. I want to point out that when we looked at the patients coming into the trial, 47% either had a normal or a very low Volta score at entry into the trial. And I want to emphasize that 16% of the controls had a normal Volta score at entry into the trial. So they've reached their primary endpoint in the control group before we treated them. And as an example, you can see the patient's legs on your right. She has a non-occlusive thrombus in the common femoral, not a large volume thrombus, and she was randomized to anticoagulation and did very well. The patient on your right, has occlusive thrombus in his iliofemoral system, and you can see the phlegmatic limb, these terribly swollen, painful limb. Well, in good conscience, I couldn't randomize him. He needed to be treated because he would have a severe lifelong post-thrombotic morbidity if he was just treated with anticoagulation. So there's some bias, there's built-in bias. And when we manage this patient, you can see the extensive occlusion of his iliofemoral system and the very good response he had after about 20 hours of catheter-directed thrombolysis, and the blue arrow demonstrating the residual obstruction of the left common iliac vein. The patient is in the supine position in this venogram. And that responded very nicely, as you see the frame on the final frame on your right. That responded very nicely to venoplasty and stenting, and he did very well over long-term follow-up. But he wasn't in the trial because of our concern for his post-thrombotic morbidity should he be randomized to anticoagulation alone. So not all iliofemoral DVT patients are the same, and such differences likely impacted the primary efficacy outcome of the ATTRACT trial. So the ATTRACT trial did not meet the primary efficacy outcome, but if you look at the average Volta score post-treatment, there was a significantly lower Volta score in the PCD patients than the control patients. There was a significant reduction in moderate and severe post-thrombotic syndrome in the PCDT patients, and there was a significant reduction in pain, significant reduction in swelling, and a significant improvement in quality of life at 24 months after entry into the trial in those patients who were randomized to pharmacomechanical thrombolysis. And although there was a numerically higher risk of major bleeds, there was not a significant difference in major bleeding in the ATTRACT trial in the PCDT versus the control, whereas there was a significant difference in bleeding in the other two trials. But if we look at the detailed results of these three trials head-to-head and put it into perspective, I think we can gain some insight. So here's the three trials. Remember the KVENT and the KVA trial, just plain low volume drip technique, and the ATTRACT trial, pharmacomechanical thrombolysis, high pressure pulse spray up front, and a high volume delivery of the lytic agent. Well, you can see that the duration of infusion was significantly shorter in ATTRACT than it was in the other two trials. The volume of infusion of the lytic agent was significantly greater. It was 3 to 4 times that volume in ATTRACT compared to KVA and KVENT. So very low volume infusion in the KVA and KVENT trial, high volume infusion in ATTRACT. The dose, as a result of the shorter duration of lytic infusion, there was a significantly lower dose of plasminogen activator in ATTRACT compared to KVA and the KVENT trial, with the resultant lower risk of major bleeding in ATTRACT compared to the other two trials. And here we see that no, ATTRACT did not reach its primary goal of a significantly greater number of patients reaching the Volta score of 4 or less. But there was a significant increase in the reduction in moderate to severe post-thrombotic syndrome, pain, edema, and quality of life in ATTRACT, whereas that was not the case in the other 2 randomized trials. So, to answer the question, does a strategy of successful thrombus removal result in less post-thrombotic morbidity? The answer is yes, a resounding yes, but remember, technique matters. And the results of these trials that were hidden in the manuscript will help us understand, once we see them, as I've pointed them out to you, will help us understand what's important technically in the management of our patients. Thanks so much for your attention.
Thank you, Dr. Camarada.
Next, we'd like to invite Dr. Lockenpaul back to the stage. We're very fortunate to call him one of our own here with 20 years plus experience and incredible clarity when it comes to stenting. He's going to help us understand in-stent stenosis.
So before I start, I'd like to acknowledge all my CVR colleagues. We would not be standing here presenting this data if it was not your trust in us and in your belief that we could help your patients, and thank you for that. So I'm presenting in-stent stenosis. When does it occur and how should we treat it? There's nothing to disclose for this talk. As we all know that chronic venous disease imposes a substantial morbidity on patients, influences their quality of life. The symptoms can be from mild discomfort to venous claudication. Signs can range from edema, varicose veins, cutaneous hyperpigmentation, lipodermatosclerosis, and ultimately venous ulceration. So in addition to conservative therapies, which were the only availability in the past, now we have minimally invasive treatments for both the superficial veins and the deep system. We've discussed superficial vein disease at extensive lengths earlier on. For deep vein obstructive disease, we have the availability of iliofemoral cable, venous angioplasty, and stenting. But with all modalities, there's always a complication which is accompanying them. So with the stents, that's what it is, stent stenosis. So before we get into the actual study, I just wanted to show you a comparison slide of all the various venous stents that are available in the market. The original stents were the wall stent, which was FDA approved in 2020. Prior to that, they were being used off-label. And they're made of alloy, which is a stainless steel alloy. They're braided design. And there is no real multi-center randomized trial for data, but there's a plethora of retrospective data available for these stents, and the primary patency rates at 5 years was 67%. Assisted primary at 5 is 89%, and secondary patency rates is 93%. The first approved nitinol stent in the US was Venovo, which is marketed by BD. It got approved in 2019. It's an open cell design. And per the vernacular study, which was the study which approved Venovo stents, there were 170 patients, and at 3 years, the primary patency rates was 79.5%. The Vichy is off the market, so we're not going to discuss that. Aubrey stents are marketed by Medtronic, got approval in 2020. Again, nitinol stents, open cell design, 200 patients, primary patency rate of 86.2%. The Zilvervina is marketed by Cook Medical, approved in 2020, again, nitinol open cell, and 243 patients with a primary patency at 3 years of 90.3%. So keep in mind that these are all comers. Basically, these trials included both post-thrombotic and non-thrombotic patients. So with wall stents, historically, we've seen a reintervention rate of 15% and an occlusion rate of about 3% has been reported in large series. And reinterventions for venous stents may include angioplasty for stent compression or in-stent stenosis, extension of the stent cephalochordate, and recanalization or thrombectomy/thrombolysis of an occluded stent, and we'll expand on that in subsequent slides. Now, this is from Dr. Raju's group by Dr. Taimur Salim. He published a paper last year, and As per that, the two important considerations with respect to venous stent ISR, the 20 to 40% ISR is common in most venous stents. Now they did not quantify the percentage of that, so it's kind of mild to severe. ISR rarely leads to complete stent occlusion, less than 10% of the patients. And what they recommend is, of course, slightly oversizing wall stents to compensate for future development of ISR, and also, which is very important, and that holds true for wall stents and nitinol stents, there is no role or recommendation for prophylactic balloon dilatation of stents with ISR in asymptomatic individuals. So if you see mild to moderate disease and the patient's asymptomatic, there is no reason to go crazy over doing an intervention on these patients. The two main factors that impact ISR per their group is stent inflow area of less than 125 square millimeters and a shear rate of greater than 100 millimeters per second. So they do a lot of basic research in their physiology lab, and that's where they came up with these numbers. And in order to counter the shear rate of greater than 100, they recommend a tapered stent profile distally in order to not create an iatrogenic inflow disease. So drug-eluting stents and balloons have been traditionally used for ISR in coronary artery disease and peripheral artery disease. And we may be able to extrapolate that in the venous world, but it may be different kind of drugs that are used for the venous stents. So coming to the individual factors which are contributing to ISR, inflow disease, when I say inflow disease, meaning there is area of the external iliac vein or the common femoral vein, depending upon where their initial stent landed, which is narrowed beneath the stent. Outflow disease, meaning the area above the stent is narrowed or the proximal edge of the stent is narrow. A new area of compression. So sometimes we have stented from a normal to a normal segment, but the patient starts complaining of symptoms, and if you rescan them, started seeing new areas of compression distal to the stent. External compression, which is most commonly seen in post-thrombotic patients who develop extensive fibrosis on the wall of the vein, what we call venosclerosis. But it's also seen in patients who have chronically compressed veins from May-Turner syndrome. Long-standing May-Turners will cause that. And this prevents complete stent expansion and may contribute to stent closure. And the same chronic compression can cause a lot of luminal inflammation, intimal fibrosis, and synechiae and web formation within the stent, and that can lead to inadequate stent expansion. One way to counter that is to predilate the lesion with the balloon before implanting the stent. Stent undersizing can also contribute to ISR, and it can also contribute to stent migration, and we saw a spate of that about 18 months ago. So we've gotten over that now. Now, patient-related factors, post-thrombotic patients typically will do much worse than non-thrombotic patients. So stents put in for patients who are chronically occluded will tend to restenose and develop or re-occlude more often than the patients who are stented for non-thrombotic lesions. If there's a history of thrombophilia, that will predispose to develop instant restenosis, and if that is suspected, the patient should undergo a thrombophilia panel before we decide on anticoagulation, long-term or short-term. Compliance with anticoagulation, antiplatelet therapy, especially in post-thrombotic patients, any kind of trauma, prolonged immobilization, orthopedic surgery. So any factors which would predispose a person to DVT can also cause stent thrombosis and occlusion. Hormone replacement therapy, and then COVID. We did see an uptick of stent thrombosis, and I had about 3 patients who ended up with stent occlusion post-COVID, and one of them was actually diagnosed while they were in the hospital with COVID. I guess it's the inherent prothrombotic nature of the infection which caused it to happen. So when we investigate and treat, it's basically signs and symptoms. So if the patient has recurrence of signs and symptoms, you start investigating. If the patient has had recanalization of previously treated superficial veins leading to recurrence of symptoms, if there is new areas of SVI, superficial venous insufficiency, which was not existing before, it's always prudent to get the stent investigated, or if there's an impending occlusion of the stent. And how we do the treatment, prompt initiation of anticoagulation therapy. So we do it right away, and based upon what the ultrasound reveals. If it's a acute or a subacute thrombus, you start them on Lovenox or anti-TNA inhibitors, or if it's a more chronically appearing process, then start them on antiplatelet therapy. Thrombophilia workup is recommended, especially if there is no real other factors which potentially could be contributing to stent thrombosis. And then the reinterventions are performed. It could be a cephalad extension, which is putting an overlapping stent above the existing stent. Choroid extension would be extending the stent lower down, so putting an overlapping stent below the existing stent. Balloon dilatation of the existing stent, sometimes that's all we need. Combination therapy with extension and balloon dilatation, and then also depending upon the characteristics of the stuff growing inside the stent, and a patient can be sent for a thrombectomy if it's acute or subacute. So I'm going to share this case study with you. It's actually a patient of mine, one of the original patients, and since I saw her in 2015, and she basically demonstrates pretty much all the factors that can lead to ISR. The mechanical factors related to wall stents. She had extensive venous there was outflow disease, inflow disease. She did not have thrombophilia, so that's the one thing which she did not have. So she was 37 when she presented to me, Gravida 1, Para 1, had been suffering from chronic pelvic pain since she was about 18 years of age. And she was actually a nurse. She had undergone about 12 pelviscopies. And before she came to me, they had removed her left fallopian tube, thinking that this may be the cause for her pelvic pain because they were not able to figure out what's going on. So anyways, we did a transabdominal duplex. She was significantly compressed, and we brought her in for a venogram. So you can see the ascending lumbar collateral. You can see the flattening of the iliac vein at the iliocaval junction. And overall, both her venous system seems to be pretty narrowed. The IVUS is on the right. You can see the IVUS catheter is parked in the IVC. We're slowly pulling it back, and you'll see compression of the left common iliac vein right about here, and then lower down. Also, the external iliac vein seems to be narrow to here. You can see the normal segment, but then once she gets into the IVC, in external iliac vein, she becomes pretty narrow there too. So the patient underwent a 24/70 wall stent. So remember, this is 2015. We only had wall stents available, and our initial practice was to use the biggest diameter wall stents because that would give us the longest length. So in this vessel, where 24/70 gave us about 100 millimeter length. You see the venogram after the stent implant, the lumbar collateral is gone, and the flow seems to be pretty good. If you look at the IVUS, you can see proximally the stent that's the stent well positioned in the IVC, and that's the classic teaching is to keep it 2 to 4 centimeters, 2 to 4 millimeters, but now we've kind of cut it down to about 1.5 millimeters, but we don't really use wall stents anymore. So now distally, you will see the stent tapers down in the external iliac vein. So overall, the luminal gain was pretty good, and that translated into symptom relief. She did very well for almost about 30 months, and she actually became an endurance athlete during this time, so did very well. Then she was regularly followed up with stent surveillance. Comes back in maybe about August or so of 2017 with recurrence of symptoms. The stent started showing instant thrombosis / stenosis, restenosis, whatever you may want to call it. And so we brought her back for a venogram again. Venographically, the stent seems to be doing okay. It seems to be patent. But if we look in the IVUS on the right, she had significant chronic thrombus buildup within the stent. The proximal edge of the stent is very, very compressed. Now, this IVUS is going from EIV up into the IVC. So that's the proximal edge of the stent you saw. It's almost completely pinched. And unfortunately, that's the mechanics of these wall stents. They're very weak at the proximal and distal edges, and they tend to do that. They get fish-mouthed at the edges over a period of time. So in any case, we ballooned the proximal edge of the stent, and These wall stents are also very difficult to balloon because they are very sharp at the edges and the balloon gets caught at the edges and ruptures the balloon. But in any case, I think we used 2 or 3 different balloons, and then we extended the stent lower down with a 18 by 60 wall stents, and this is 2017, so we still had only wall stents available. And then we post-dilated the whole overlapping segment. So overall, again, good result with the venographically and with IVUS acceptable result, I would say. And then translated again into relief of symptoms. And again, she did very well for about another 2 years, and then came back again in 2019, this time complaining of recurrence of left-sided pelvic issues, leg pain, leg swelling on the left side. So this time I brought her in I got the axis on the left pop, and we went up and did a venogram, and then the IVUS is shown on the right. And again, we parked the catheter all the way up in the IVC and pulled it back. I let this run, and then you can see it again. The proximal edge of the previous wall stent, again, is very terribly pinched, and again, significant amount of organized thrombus within the stent. And that's the overlapping stents. You can see the proximal edge of the 1860 has also kind of shrunk and is kind of moved away from the other wall stent. Sorry, I think I jumped. Okay. Can you run that, please? Okay, so this was, she got a proximal 16 by 120 stent. So what I did was, because we had the Vinovas available, and so I was able to put a overlapping Vinova stent within the previous wall stent, and I was able to project it into the IVC so that we can counter the pinched portion of the wall stent. So approximately, she had a 16-120 and an overlapping 1480. So we basically lined the 2 wall stents with 2 Vinova stents. And you can look at the IVUS, we got great results. We were finally able to open up the proximal edge of her, the wall stent. So we restored the outflow, we restored the inflow.
Wrap it up, Ralph.
There we go. So that's the IVC. Oh, I'm sorry. Can you run it again, please? Can you run that IVUS, please? Can you run that ultrasound, the third picture again, please? I guess I need to go back. I really need you to see that because it was very... Yeah, I'm trying to do that. Okay, let's see. Okay.
It's just circling.
He can't get the
All right,
video to
Max
play.
is going to work.
Wrap it up.
So it goes by sequence, so you just keep a focus on the all IVUS. Yeah, it's coming, don't worry. So there we go. You see that nice proximal edge wide open? And that's the proximal edge of that BD Vinovo. So she did extremely well. I mean, this is 2019. We've been following her since then. She actually worked as a nurse for me for a few, maybe almost 2 years. And no issues at all. She's on long-term aspirin now after these procedures. So with our experience, 90% of the patients that we treat with stenting is for non-thrombotic disease. And we have seen traditionally in our practice 15 to 20% reintervention rates with the wall stent. And most of the times the patients manifest symptoms with the wall stents at maybe about 2.5 to 5 years post-index procedure. The nitinol stent reintervention rates are lower right now because we have about a 4-year follow-up. We have to still see what it shows going further, but it's about less than 5%. And what has kept us at that is very close surveillance ultrasounds, very aggressive initial anticoagulation regimen, and extending the duration of anticoagulation therapy if warranted. So if I suspect that the patient is having restenosis early on, I will extend the antiplatelet or anticoagulant therapy for 6 months, even longer sometimes. cognizance about inflow disease at the index procedure. So we are very careful about what we see during the index procedure. If there is inflow disease, those patients are kept a very close follow-up. And then normal to normal, we have been able to do that with the availability of these longer nitinol stents. So I try to start at the proximal normal segment, which is typically putting some of the struts into the IVC and then extending all the way down distally sometimes beyond the external iliac vein into the common femoral vein. And we are able to do that because of the availability of the longer nitinol stents. The longest Venovo stent is 160 millimeters, the longest Abre is 150 millimeters. So that helps us to do that. So before I finish, I just wanted to share this slide quickly with you. This is a first-of-its-kind study which was published in 2022 out of this group out of Michigan and Rhode Island, the pathologic characteristics of human venous stenosis and stent occlusion. So what they did was they used a microtome to did stent biopsies at an area which was 1 millimeter or more thick, and then they analyzed it pathologically. And this is what they found, that they analyzed 254 stents. 59% had fresh thrombus, which could be present in stents placed up to 32 weeks. And the approximate age of this thrombus was 0 to 2 days. Organizing thrombus was seen in 57% of the cases, and it tended to decrease over time. Old thrombus, which is thrombus material greater than 2 days of age, was seen in relatively few patients, few stents, 18%. And the most common was DIT, what you call diffuse intimal thickening or intimal hyperplasia, seen in 80% of the stents. However, they did find that 49% of the samples did contain both organizing thrombus and DIT, and this was seen more after 4 weeks of stent implantation. And the calcified material, which we normally see in very old wall stents, was seen at 104 weeks of age. And this was the rarest finding, only in 6% of the stents studied. And this just gives a schematic of the two. Thank you.
Thank you so much, Dr. Lockenpaul. Next, would Dr. Gasparis join us again? He needs no introduction. I love the ribbing, with the guys. So anyway, 27 years of experience as a vascular surgeon, and who better than to break down these guidelines for us than a former American Venous Forum president?
All right, so what are the guidelines? These are the papers. Thank you. So basically, there's a couple of papers I looked at, used that was the American Society for Hematology in 2020, and then the CHEST guidelines from 2021. These are the newest ones when you look at management of patients with deep vein thrombosis. So how do you manage a hypercoagulable patient? So what is hypercoagulability? So it's basically a group of hereditary and acquired conditions that leads to thrombosis, whether it's in the veins, arteries, or both. And you can see here the factors that are acquired as well as hereditary. And not all patients, though, that are hypercoagulable or have hypercoagulable risk factors develop a thrombosis. And conversely, not all patients that get a DVT have an identified risk factor. When you look at both the ACCP and the American Society of Hematology, they break down, okay, so it's a little too far. So they break down risk factors as either transient or chronic or persistent. And you can see here the ACCP further subdivides the transient risk factors, whether they're major or minor. And then, of course, you have those patients who have no identified risk factors or unprovoked thrombosis. So you can see there, major surgery over 30 minutes, admission to a hospital for more than 3 days. Those are major transient risk factors. And then minor is like less than 30-minute surgery, less than 3 days in the hospital, pregnancy and stuff like that. So the first thing that you want to do when you identify a patient with a VTE is to see what are those risk factors, because it's not going to really change your management in the short term, but more importantly, it's going to change what's your long-term management, and we'll talk about that later. Interestingly, in both the ACCP guidelines and the American Society of Hematology guidelines, they note that patients who has risk factors that are inherent to the intrinsic, such as they talk about age, sex, but also presence of hereditary thrombophilia, does not classify it as a persistent risk factor. So just keep that in mind. So obviously, patient gets a VTE, you start your initial management, and your primary treatment is either anywhere from 3 to 6 months, depending on which guidelines you look at. And this is standard across the line. Then the patient should be reevaluated, and based on what their initial presentation was with respect to risk factors, they kind of determine what is the secondary prevention. Do you stop anticoagulation at 3 months, or do you continue for secondary prevention? So let's start off with primary treatment. Now, whether the factors that led to this were provoked or unprovoked, transient or chronic, really the guidelines are no different. It's 3 months for ACC when you look at the chest guidelines, and then the hematology guidelines talk about 3 to 6 months. And this is based on the fact that when they looked at the literature, there's really was no benefit whether you treat them for 3 to 6 months versus 6 to 12 months. The risk of rethrombosis is not reduced by extending therapy out to, let's say, a year. Now, for secondary prevention, again, looking at risk factors, transient, chronic, or unprovoked, when you look at the transient risk patient, whether that's major or minor, after they complete their primary treatment, there's really no role for secondary or no recommendation for secondary prevention. In the group of patients who have chronic risk factors, this is different. So, or unprovoked DVT, they talk about providing secondary prevention. And the decision here depends on several things: patient preference, risk of recurrent VTE, as well as risk for bleeding, for treating long-term. And then the question is, what do you treat it with, and for how long? And we go a little bit into that. So secondary prevention, the first thing they talk about is, you typically in the past we used to say, okay, after your primary treatment, start on an aspirin for provoked events in order, or unprovoked, to prevent recurrent thrombosis. Both guidelines recommend anticoagulation over aspirin. In the chest guidelines, the recommendation is a DOAC. In the hematology guidelines, it's either DOAC or vitamin K. Actually, vitamin K or DOAC, that's the order they recommend. But regardless, the DOAC recommendation is prophylactic dose, 2.5 milligrams of apixaban or 10 of rivaroxaban, and that's recommended more over the standard dose, again, looking at risk of rethrombosis and bleeding risk. And if you're going to treat somebody with secondary prevention to prevent recurrence, they recommend therapeutic dose of Coumadin. So what do you do if anticoagulation is discontinued? Again, here, the patients with unprovoked events who stop anticoagulation and do not have a contraindication to aspirin, they suggest continuing aspirin at these patients. So aspirin really only plays a role here if the decision is that there's no value of secondary prevention with anticoagulation. Now, neither the chest guidelines, as I mentioned earlier, or the hematology guidelines consider thrombophilia, hereditary thrombophilia, as a persistent risk factor, and don't talk about what the long-term anticoagulation or secondary prevention in this group of patients is. But more importantly, what are the factors that I mentioned earlier as far as acquired, whether the incidence was primary or secondary, provoked or unprovoked. And if the risk factors were transient or chronic. So this is actually out of the Society of Hematology, separate from their guidelines, and they break down the hereditary risk factors as type 1 or type 2. Type 1 are really rare conditions, and it's a small percentage of the population who presents with VTE. Type 2s, like the factor V and prothrombin gene mutations, those are more prevalent, 30 to 50% of the population who present with thrombosis. And I'll just go through a few of these. none of the hereditary factors really is there a role for prevention if there's never been history of VT. So no benefit for long-term anticoagulation. In women who have factor V, they do recommend avoiding estrogen-containing contraception or hormone replacement therapy to prevent thrombosis. But otherwise, there's really no role of anticoagulation if there's no history of VT. If there is a history of VT, recommendation is DOAC for 3 to 6 months, and after that, there's really no role for long-term anticoagulation. Prothrombin gene mutation, same thing for if they're heterogeneous mutation and no other risk factors. There's no need for any anticoagulation as a primary prophylaxis. If there is a history of VT after initial DOAC treatment, evaluate the associated reversible risk factors, and it's recommended that patients who undergo anticoagulation for at least 3 months. And again, here, lifetime anticoagulation in cases only if there's been a recurrent event, not as a secondary prevention in these cases. Factors C and S, deficiency with no history of VT. There's not enough evidence for any recommendation for with no history of VT, but with history of VT, again, here, low molecular heparin for 5 to 6 months, followed by vitamin K or DOAC. If there's other clotting disorders, multiple clotting disorders, they do talk about prolonged indefinite anticoagulation. Finally, antiphospholipid syndrome. Again, no role in prophylaxis. Some authors suggest using aspirin low dose in these patients to prevent VT. But if they do get an event, vitamin K agonist is a preferred treatment. DOAC is really not recommended because of the lower efficacy in this group of patients. And secondary prophylaxis is recommended in these patients with a target INR of 2 to 3. And if they do get a recurrence despite being on Coumadin, then the INR target should be over 3. So kind of in summary, you look at your factors, your risk factors, whether it's acquired, hereditary, and break them down whether they're provoked transient, provoked chronic, or unprovoked. And then your primary treatment, that's not going to really affect your primary treatment, which is going to be 3 to 6 months. More importantly, it's going to determine your secondary prevention, and really only in those group of patients who have provoked chronic risk factors or an unprovoked event. Thank you.
Published on this subject greatly. Floor is yours.
Thank you, Dr. Soufian. I think my presentation will fit in nicely with the previous presentation, and hopefully we will avoid any overlap and get done soon. Again, I am a big fan of the guidelines, and I think for those of us that flounder a little bit or just learning, these guidelines really provide a good reference point for us to start. But I also think that each clot has a personality, and the fear I have, similar to you, Peter, is that if we just follow the guidelines and stop thinking, we might be over and under treating patients based on this. So there were some changes from 2016 to the present guidelines. The ones I would highlight is the introduction of the lower dose anticoagulation, and it'd be nice to see what the bleeding risk is going to be in the long term with those patients, because that's the balancing act, right, is preventing recurrence, but also not letting people bleed unnecessarily. Another change was the change from, in cancer patients, they used to recommend Coumadin and Lovenox, and now they've switched that to the DOACs also. As previously mentioned, we start to subdivide and categorize these clots even further with the major and minor risk factors. Now, the Garfield trial or the Garfield registry is very fascinating to me because this is the first opportunity we've had to really look since the guidelines changed the use of DOACs. And this was an observational study of about 10,000 people, and it just tracked what the treatment was, divided the patients into provoked and unprovoked clot, and those were provoked by a transient factor. And they looked at whether a DOAC was prescribed or vitamin K agonist, and they tracked them over time, and they found that, unfortunately, even with these recommendations being pretty consistent since 2016, we still see a great deal of patients being treated with anticoagulation out a year, even for these transient events. And the conclusion from this paper was that the providers are more concerned about recurrence than they are about bleeding risk. And so that begs us to answer the question, why are we doing long-term anticoagulation anyway? We all get the short-term benefits, but what are the long-term benefits? And I think we have to do a deep dive into post-thrombotic syndrome and the recurrence, because those are the topics we talk most about as the consequences of VTE. In order to understand that, I think we really need to understand, well, what recurrence rates are we even talking about? Like, how significant is this? And if you look at a clot provoked by surgery, so you had a hip surgery and it has a high incidence, the annual recurrence rate is 0.5%. If you had it provoked by a medical condition, it's 2.5%. If it's unprovoked, it's 5% per year. Second unprovoked is 7.5 per year, and malignancy has a 15% risk per year of clot. And so it's important to have those numbers in your head when you're talking about exposing someone to a 2 to 3% per year bleed rate. What are you protecting them from? And so a lot of us make an emotional decision. You know, you have a life-threatening PE, you know, we have an emotional response. We certainly don't want to have that again. And does that influence, or should that influence, what we do long term? And the answer is people with proximal DVTs tend to have a higher recurrence rate than patients with isolated caffeine clots by 50%. And we also see that patients that presented with a PE have a threefold higher likelihood of presenting with PE in the future. So that's pretty scary. Now, what you also notice, though, is the REAT registry. The REAT registry looked at 11,000 patients or so, and it started to identify when the patients present with clots, what are the risk factors, what were the provoking factors, and you start to see these risk factors kind of sort themselves out a little bit. So if you get a clot from travel or estrogen or surgery, we're starting to see those more they present as more distal clots more commonly versus pregnant patients, elderly patients, cancer patients, patients with history of VTE, they tend to present with more proximal clots. And so you start to look at a clot and I start to try to identify its personality. Another thought is that should anticoagulation be used to reduce post-thrombotic syndrome? And when they looked historically at data before Coumadin and then after Coumadin, they found that the risk of post-thrombotic syndrome was reduced by 78%. Seems pretty good. But then they also identified that only 60% of the time was spent in the therapeutic window. And oh, by the way, the first month tends to be the most critical month. That's when the fibers get more porous and the fibrinolysis can occur better. And so hence we see the switch to the DOACs, hoping that that's going to get better. And I'm looking forward to some evidence from the Garfield trial that there is higher recannulization rates. But the other thing we have to talk about is all these studies have been done on Coumadin, right? And most of us know Prandoni's open vein hypothesis. And I think intellectually it just makes a lot of sense to most of us. And in 2017, what he did is he looked at first episode of VTE, scanned him at 3 months, scanned him at 6 months. Yeah, the slides, it's hard to see these. But at 3 months, there was 41% residual vein thrombus versus 6 months, it was 21%. If he compared that to historical data on Coumadin, the extension of that anticoagulation didn't really reduce the residual thrombus there. So it's something to just keep in mind. We don't really know how long the DOACs, if this would extend out a year, would we see even further resolution of that clot? So I think that's something that's still kind of on the table. Now, there were some studies specifically to address this. The EXACT trial answered the question, does extended anticoagulation reduce the risk of post-thrombotic syndrome and improve quality of life? So there were 281 patients with unprovoked proximal clot. They were treated with 3 months of treatment, standard, and then they were randomized to discontinue or continue for 2 years. And the outcome data was looking at the Volata scores and quality of life, and there was no difference. Stain then compared 6 months of anticoagulation, 6 to 12 months or greater than 12 months, and said that also did not influence the risk of post-thrombotic syndrome. Excuse me. Schulman then followed patients that were treated with 6 months and 6 weeks and compared those out 10 years and found that the recurrence rate was higher if they were treated for shorter courses, but the post-thrombotic risk was not. And so they concluded then that the use of anticoagulation should not be done for the sole purpose of reducing the risk of post-thrombotic syndrome. So this is a question that I grapple with often is, should residual vein thrombosis influence our decision? And the answer is the guidelines say no. They don't see any reason for that, but the evidence is all over the board for this. And again, if you're a believer in the open vein hypothesis, it would stand to reason that an open vein would have a lower risk of recurrence. The DACUS trials are the ones that specifically ask this question. They took patients with first DVT. There were 258 patients, and these were both provoked and unprovoked. They were treated for the standard 3 months, and then an ultrasound was performed to see if there was residual clot. If there was no residual clot, then the anticoagulation was stopped, and the recurrence rate was about 1.3% at 1 year. If there was residual vein thrombus, the anticoagulation, they were randomized to either continue for an additional 9 months, so they would be treated for a year, versus no anticoagulation. And they actually had to halt the study because the recurrence rate was so high in the patients that discontinued the anticoagulation. So that would kind of push you to maybe lobby that longer anticoagulation really should be considered in the patients that have residual thrombus. The extended DACUS trial then took it a little further, and it looked at just unprovoked proximal clot. These patients are traditionally going to scream, I'm going to have a high recurrence rate, right? High post-thrombotic syndrome rate. All these patients were treated for 3 months with anticoagulation. Again, they had the ultrasound. A third of these patients had no residual thrombus. They stopped anticoagulation, and at 1 year, the recurrence rate, again, was 1.4%. Now, 66% had residual vein thrombosis. They were randomized to continue for an additional 21 months, so a total of 2 years. And what they found, the recurrence rate at 1 year was 10% in this patient population. And it wasn't necessarily limited to that one leg, which speaks to the fact that there's probably some hypercoagulable state that's ongoing in these patients. And I think the takeaway I had was that if I do see a patient that had a proximal clot that has resolved, I think that screams favorable prognosis with a low recurrence rate. So I think that was the major takeaway there. And what difference does it make? You know, we have the primary care people putting a lot of people on blood thinners. I do too. But I think we really don't have a lot of real great models to do a risk assessment for the bleeding rate. And I think Kieran published that there's a 6-fold major bleed increase if anticoagulation is extended past that 3-month mark. So the risk assessment model that I look at is his model, which, you know, you think about your DVT patients, if you have any of these characteristics listed on the left, you only need 1 point to double your risk of bleeding. So the risk of bleeding, if you have none of those things, is 0.8% per year. If you have one thing, if you're over 65 or you're immobilized, you're 1.3, and if you have 2 of those, your bleed risk exceeds 6.5% per year. So I think it really does beg us to differentiate each patient case by case to really identify who's going to benefit, what is the risk of recurrence, who is going to benefit from it, and what is the bleeding risk. And I think if we have upfront conversations with our patients and we're knowledgeable enough to give them good data, they can make decisions, but these should not be emotional decisions. These should be medical decisions. Thank you.
Thank you, Dr. Kelsey. I think we have a few minutes before we wrap this for the room to be prepared for the next session or for dinner. If I could ask our speakers to come to the podium. Appreciate it. Thank you. Well, I will ask the first question. Dr. Diaz, I have read some of the works again that I mentioned to you, and in the marine model in mice that you have studied for recurrent thrombosis, you noted that structurally the recurrence in model that you used is significantly different than the primary venous thrombosis. And specifically, it is really the vein wall proliferation and the fibrosis and so on. If that model speaks true to humans also, to our own clinical practice?
Thank you for the question. I think the question is if we have models available for recurrence DVT. And when we try to model deep vein thrombosis, usually is one DVT episode, and when we try to parallel with human, and that is very important to keep in mind. Now, years ago, we developed a model, I think it was published in 2015, which is an open vein. Taking that model in consideration, we anticipated to do a second deep vein thrombosis in the same animal model, and we published that also, which is 2 episodes of deep, venous thrombosis in the same animal, in the same vein. Having said that, results of that second event, it provide biological characteristics that are different to one episode in the chronic stage. But it's hard to consider that is a model of recurrence DVT. Sometimes, as the doctor mentioned in the recent talk, the DVT occurred in the different legs. So that is something that we didn't model yet. Thanks.
Oh, go ahead, Peter.
So, Dr. Camarada, I know that you're on the steering committee for C-Tract. So I have 2 questions for me. Is Villalta still being used in V-Tract, or are they using RVCSS? And the second question, I agree with you completely about technique matters. Have they opened up C-Tract to other mechanical thrombectomy devices like the, I forget, the big net one that's used right now, the ClotTriever?
I'm awfully sorry, Peter. There's an echo here.
Yeah. So the first question is,
pick up the question.
Yeah, is RVCSS or Villalta being used in C-Tract?
In C-Tract. I believe it's the Villalta score.
This is Villalta. In CAVA, it was definitely Villalta also, and I was going to ask the same line, because in ATTRACT, when you wrote your paper, if it was VCS that was to be relied on, the conclusion would have been quite a bit different. And the fact that my question is, Peter, you always say this, the low Villalta is more useless to me. As a matter of fact, right, I'm coming to conclusion to that. And we see that the whole study is a reflection on how bad Villalta is and not the treatment. And Kelsey, you also just presented that there was a difference in when they checked the Villalta, 5 versus 5.9. Again, it's the problem of the low Villalta and not the fact that the prophylactic treatment is not useful.
I think that the proper design for trials now going forward, if we were to use a Villalta score, I would use a threshold such that I would not enter a patient into the trial if they had less than an 8 or 9 Villalta,
correct.
so that you have an opportunity to improve. I showed you one example of a patient classified as having iliofemoral DVT, and she met all the entry criteria, but we had no threshold for Villalta score in ATTRACT, which I think was a mistake. And I take part of the responsibility for that because I was one of the co-authors.
Did you get one?
Yeah, go ahead.
Well, thank you. We have a question from one of our virtual audience, and it's quite short. I'll read it. From Anonymous, how is primary in-stent stenosis defined against re-stenosis? I think I'm not.
So I guess, so primary in-stent restenosis mean you put an index stent and over a period of time that stent develops thrombus buildup or stenosis. So, I mean, it's an interchangeable term. You can say primary stent stenosis, you can say in-stent restenosis. Restenosis, I guess, is from the fact that there was an existing stenosis in the vein and you treated it with a stent and now there's a stenosis again, so you call it restenosis. So I don't really think, I mean, it's just a matter of semantics, I think.
Okay, thank you. Next.
If I could just, the beauty of all this technology, we just got a text message from AI. Oh, sorry. Okay, AI tells us that it's the VCSS for CTRACT as a primary endpoint and the Villalta score as a secondary endpoint.
I have a question. It seemed like the new guidelines kind of moved away from the mechanical thrombolysis and kind of made it reserved for severe cases. What are your thoughts on that?
Well, when I was on the committee, we, after an awful lot of debate, we did recommend either venous thrombectomy or catheter-based techniques to eliminate thrombus. Now, I rotated off the committee, and I'm no longer on the committee. Oh. And I think that just looking at the patients that we treat, and you can look at the clinically meaningful outcomes for ATTRACT and the other trials in comparison. And the data are very strong, very supportive of restoring patency to at least the iliofemoral venous system. There was absolutely no signal of quality of life benefit for catheter-directed thrombolysis in the femoral popliteal segment.
So I have another question. This one is for Laura and for Tony. So one of the things that has always stunned me when I look at the guidelines is that there's never any mention of the utilization of duplex scanning to kind of guide your decision-making as to the length of anticoagulation. So Laura, I was really captivated by that one study that you showed because I wasn't aware that that study existed, that if your duplex scan shows that there's still residual thrombus, there's a higher recurrence rate. So could you talk a little bit, because what I do is at 6 months, especially if it's an iliofemoral DVT, and I rescan them, if there's residual disease, they get a year. And I based that based upon old data from when I was a resident, but it seems that DACA study kind of supports that decision-making model, is that if the ultrasound showed you there's residual disease, there probably is some benefit to anticoagulation. So can you and Tony both talk about whether or not that's true and whether or not you utilize duplex scanning to help guide your decision-making on length of anticoagulation?
My takeaway was if the clot is gone, even in an unprovoked patient, which I would traditionally say I wouldn't expect that clot to be gone, if that clot does reabsorb, it characterizes that as a safer situation for me to stop the anticoagulation versus extended treatment. I think that study was a good study in the short term, but the recurrence rate, even when you stop the anticoagulation in the group that didn't have it resolved, they had a very high recurrence rate, so that would argue for extended anticoagulation in that patient population. I would agree. So I'm confused as well why that isn't incorporated more into our decision-making, and in my practice I do. I don't know if it should be 3 or 6 months, so I look at them in 3 months, and if the clot is gone, I feel pretty good about it, and I usually take them off the anticoagulation.
Yeah, I kind of am confused too about it, but, and I do the same thing. I use ultrasound to kind of determine if I'm going to stop at 3 months or 6 months. I think based on both, in the ACCP guidelines, and I don't remember exactly in what situation, they do mention using ultrasound or D-dimer if you're on the fence, whether you stop or continue. But it's not part of the recommendations. So, I mean, personally, like I said, at 3 months, if everything's clean, I'm done. If there's residual, I continue to 6 months based on ultrasound. But if they're still there at 6 months, I typically, if it's a provoked transient event, I stop the anticoagulation.
I have a question for
If I may, I think that if my memory serves me correct, in the DACAS trial, there was a threshold of a 40% luminal reduction of residual thrombus, and that was the point where they randomized that group to ongoing, they used the ultrasound, then ongoing anticoagulation versus placebo, and there was a significant benefit to ongoing anticoagulation. And likewise, the French investigators used D-dimer as an indicator of anticoagulation, and they had the very similar protocol, whereas they drew the D-dimer values, and if the values were normal, those patients were discontinued. But if the values were high, then that group was randomized to ongoing anticoagulation versus not, and there was a significant benefit to anticoagulation in patients with a persistently elevated D-dimer.
any question from the audience or comments?
I think the other thing about the DACAS trial, when they did that, they only checked 2 spots. Like I think they looked right at the femoral vein and the popliteal, and so they didn't do an extensive hunt for clots like we do. So it was just a 2-point check.
Go ahead, please.
So if you're going to extend your treatment of acute unprovoked proximal clot from 3 months, do you typically do like monthly ultrasound and get them off sometime between 3 and 6 months, or do you just fully commit to a 6 months period and then reassess thereafter?
I bring them back at 3 months and see how they're doing, and if it's gone, I take them off, and if not, I'll bring them back at 6 months. I think the idea that I have is that clot going to go away at 6 months, and that's the thing I don't know about the DOACs, because that Prandoni's study tracked these patients for 6 months follow-up, but I don't know if that number keeps going down at 9 months and a year to support ongoing anticoagulation. So,
but you would, if you see it still there at 3 months, you continue another 3
Yes.
and just see them 3 months out?
yes.
Okay, thank you.
I'm under the impression, if my memory serves me correctly, that unprovoked deep venous thrombosis, proximal, as they term it, proximal DVT, unprovoked, and an unprovoked pulmonary embolism requires indefinite anticoagulation. Is that not the case?
Not with the first episode,
Well,
Unless there's a thrombophilia.
no, I would do extended anticoagulation in an unprovoked patient just because of the risk, but
But I thought the guidelines stated that the 2016 guidelines state indefinite anticoagulation for an unprovoked venous thromboembolic event. Now, there's another interesting observation in terms of bleeding. When you, and that's our concern, and the reason why not to continue is the risk of bleeding. But if a patient's at risk of bleeding, they're more likely to bleed in the first month of therapy. And then if they don't bleed in the first month, then the next threshold would be 3 months of therapy. And if patients haven't bled by then, they're at a low risk for bleed. And that can help us in terms of our clinical judgments on therapy.
Thank you all. For the sake of time, I'm going to wrap it and I hold my question and ask them privately. Thanks, everybody.